disorders, a group of disorders in the DSM-5 that are really very interesting. So our objectives for this presentation are to describe the clinical manifestations of each of the somatic symptom disorders. We're going to talk about the origins of these disorders as well as treatment strategies. There are 1, 2, 3, 4, 5 under this umbrella. The somatic symptom disorder, illness anxiety disorder, which was formerly known as hypochondriasis, conversion disorder, which is now functional neurological disorder. There are those psychological factors that can affect medical conditions, and then we're going to talk about 2 presentations of fictitious disorder. So somatic symptom disorder, the first in the DSM-5 under this umbrella, when persons present with this diagnosis, they are typically experiencing a whole host of distressing symptoms, physical symptoms primarily, and they will express an extensive amount of symptoms. So maybe my head hurts, or I'm not sleeping, I feel tired all the time, I've got tension, neck pain, back pain, shoulder pain, back pain. It's an extensive array of symptoms. It's important to know that these symptoms, though, are real. These are not symptoms that are made up or fake. So be very empathetic and acknowledge that you believe their symptoms are real. But what you find in the workup is that there are no physical explanation, and often these folks will endure a great deal of suffering and have a lot of functional impairment. So you can suspect SSD when there are multiple organ systems involved, if there is a chronic course and an absence of any physical or structural anomalies. So you kind of get the picture. There's going to be big workups with these folks, and you tend to see normal diagnostic lab findings as well. The next disorder is conversion disorder or functional neurological disorder. These disorders are accompanied by neurological symptoms. So the primary difference between conversion disorder and somatic symptom disorder is that with conversion disorder, you see just neurological symptoms. With somatic symptom disorders, you're going to see multiple different symptoms that might have some neurological symptoms, but there are a whole host of other types of symptoms that are not neurological in nature. So, conversion disorder, common symptoms: paralysis, blindness, movement or gait disorders. Maybe this person all of a sudden they woke up one morning and they're not able to walk anymore, or maybe they have one extremity that's not working, so they might look or appear as if they've had a stroke. A classic presentation with someone who has conversion disorder is that they're just not really distressed about having the symptom, and they might experience a really significant disability, but they're just indifferent about it, and we call that label indifference. And you might see that on boards, or in your testing you'll certainly see it. But so you can approach them and say, oh my gosh, aren't you upset because you're not able to see anymore, or you can't walk? And they'll be, no, I'm not really. They're just content with it. Maybe a little distressed, but not to the extent that you would expect them to be. So the key with understanding or treating conversion disorder is to be able to identify the trigger. And so there is, most often with conversion disorder, a recent stressor that you can look to and say, oh, so this was happening, and the symptom was an unconscious present, or an unconscious physical response to something that you didn't really want to do or you were extremely anxious about. So, an example, classic, is maybe someone who does not want to get married, the bride who doesn't want to walk down the aisle, all of a sudden is stricken with paralysis on the day of her wedding, but does not feel free enough to express her desire not to get married. So something inside of her has said, whoa, we can't go through with this, so she's stricken with paralysis. Um, Often we'll see maybe college students about to go off to college be stricken with seizures, unexplained seizures. So this can be a type of this is a conversion disorder as well. So conversion disorder is relatively common. So the key here with conversion disorder is if it's a person who presents with a neurological symptom such as paralysis, blindness, lack of movement, numbness, then and there's no physical reason for this, then you need to identify the precipitating stressor. Okay, moving on to illness anxiety disorder. So this is used to be known as hypochondriasis. So these are the folks who, regardless of normal testing, they are convinced beyond a shadow of a doubt that they have a serious illness. They tend to misinterpret physical sensations as being something of outside of major illness. So I am convinced I have cancer. I know I'm going to die. I don't care what you say, I know it's there, and they will keep pursuing diagnostics until they find someone who will confirm their worst fears. So they have a lot of anxiety about their health, excessive health related behaviors, or maybe even maladaptive avoidance. So, but maybe care seeking or care avoidance. So you have one person who says, I am sure I have this, so I am not going anywhere near providers, but yet they have extreme anxiety about illness, or they're going to be excessively seeking out providers. So some folks will experience or become very focused on the illness they have, that they will become excessively anxious about it and develop depression and experience high levels of stress. So a good example is the person maybe who suffered a heart attack while they were engaged in intercourse. And so therefore they're going to avoid any type of romantic encounters for fear of having a heart attack. So they experience an extensive amount of dread. Another good example is someone who maybe experienced a lethal arrhythmia like ventricular fibrillation, and now they have a defibrillator implanted. So they're always anxious that this thing is going to fire, and of course that would be really scary to have to walk around with that fear all the time. So they have a lot of anxiety related to their physical condition. So etiology, we know sometimes these are inherited from family members. There are certain biological factors that can put you at a higher risk of developing somatization disorders. Psychological factors, maybe these are learned. Maybe you have a parent or a sibling who maybe suffered from lots of anxiety related to illnesses. So there could be learned helplessness. Persons who have the personality disorders of dependency that foster dependency, like a dependent personality disorder, or maybe avoidant personality, they might develop more physical symptoms as a way to, stay in that learned helplessness. And then there are the cognitive theories that stress the importance of, what we think drives our feelings and behaviors. Some certain cultural considerations to explore are those folks who find it taboo to have any type of mental health condition or diagnosis. So they have physical symptoms as a way of expressing psychological distress. So whenever I approach patients that are, use where it's suspected that this is a somatization disorder, it's important to ask them right off the bat, do you believe that a person can suffer physical symptoms as a result of psychological pain? And most people will answer yes to that question. And then you can start from there. Because all too often, people with somatization disorders are dismissed and told that they are faking their symptoms. And this, of course, just causes terrible distress and a breakdown in the provider patient relationship. So, certain psychosocial factors, especially for conversion disorder, you have to look towards or look to current or recent life events that might have been the primary stress that triggered the event. What is their level of coping skills? Obviously, folks who have stronger coping skills are going to be less likely to have these types of physical manifestations of psychological trauma. Spirituality and religious factors, identifying secondary gains. People with the somatic symptom disorder, conversion disorder, illness anxiety disorder, they are not really aware of secondary gains. However, in the fictitious disorders, which we're going to cover in a minute, they do have secondary gains that we're going to discuss. And of course, what is a person's cognitive style? Do they have an internal locus of control or an external locus of control? Those persons who have an external locus of control typically are going to be more vulnerable to these types of disorders because they feel less in control of their life. So, talking with patients about their abilities to communicate feelings and their emotional needs can be a key finding in your assessment. So, persons with these disorders might have a really difficult time expressing themselves, and this is why a lot of their psychological symptoms are expressed in physical symptoms. So, is there a dependency on medication? And again, that might point to someone who has a fictitious disorder rather than the SSDs. And then, of course, self-assessment. It's really important to, do your own self-assessment to determine, are you going to be able to build trust and rapport? Do you recognize that these individuals are truly experiencing these symptoms? And of course, asking your patients, what is your perception of your symptoms? Where do you think they come from, and how do they contribute to your psychiatric or psychological distress? These are nursing diagnoses of ineffective coping, obviously, anxiety over the symptoms. There's often a risk for loneliness because they're not able to function at a level where they're able to attend social activities or even work. A sense of powerlessness and hopelessness. They can't get a diagnosis. They can't find treatment. They are not getting better. The social isolation, the pain. Remember, these symptoms are genuine and really felt. Altered family processes, these types of symptoms can cause significant stressors within the family, and of course risk for suicide associated with that sense of hopelessness, helplessness, and how it leads to just severe depressions. So shared decision making is all about developing trust with your patients so that they can feel or become actively involved in their care. You can work with them on developing insight, helping them to identify the factors that are contributing to these physical symptoms. So you need your patient's participation. So again, that's all about establishing a good relationship and building rapport. Steps are small and incremental, and your outcome criteria needs to be focused on goals that are realistic, measurable, and attainable. So the relationship, very important. Educate patients regarding treatment, and treatment is going to be primarily focused on therapy. So therapy, primarily cognitive behavioral therapy techniques, can be incredibly helpful. Dialectical behavioral therapy that teaches maybe emotional regulation, support groups or systems, and working with patients to develop effective coping skills, and focus on their strengths, their levels of resilience, and reinforce those skills, and try to encourage patients to do things for themselves. So it's really important that there is a continuity of care. You want to encourage patients not to doctor shop, to stay with one consistent provider, especially avoid unnecessary procedures and diagnostics. Patients can, have access to frequent, brief, regular visits. Always conduct a physical exam. Don't be dismissive of their symptoms. Avoid disparaging comments like, these symptoms aren't real, or this is all in your head. That's horrible. And patients will say, I've been told that this is all in my head, and that's really quite cruel. Set reasonable therapeutic goals. Folks with these disorders, they don't get well overnight, so it has a slow, chronic, progressive course. So set reasonable therapeutic goals. Coping strategies that can preclude somatization. You want to promote self-care activities, help them to learn to be assertive, to speak up for themselves, to be their own advocates. Pharmacological interventions might include some antidepressant medications, anti-anxiety medications, but be careful not to prescribe things that they can become dependent upon, like the benzodiazepines. So incremental use of benzodiazepines might be helpful, but certainly not on a regular basis. Health teaching and promotion, and these folks might need case management because of their excessive use of healthcare services. So case management can help with navigation and minimize overuse of resources. So psychotherapy, using a holistic approach is especially important because, again, this is a very complex illness, and you need to factor in all of those environmental, psychological, spiritual, and social cultural issues associated with the illnesses, and factor those into your treatment plan. CBT, very, very good, and make sure that you advocate for your patients, act as a consultant or a liaison. And there's where case management, that role of case management, comes in as being so important. So evaluation of your care needs to be focused on, did you set clear, realistic, and measurable goals so that you can achieve good outcomes? And if your patients are able to experience a decrease in their somatic symptoms, and so instead of, when your patients come back to you and you're asking them how they're doing, it's try not to focus so much on the somatic symptoms, but see how they're communicating with you. Is there less focus on that? So what you should expect to see is a gradual decrease in their reports of distressing somatic symptoms. The key here, though, is to treat early, especially with conversion disorder. If you don't respond to conversion disorder in a timely manner and identify exactly the precipitating cause, then this can turn into a long-term problem. So we're transitioning into fictitious disorder, and these are pretty scary. So, with fictitious disorder was formerly known as Munchausen syndrome, and you probably heard a lot about Munchausen syndrome or Munchausen syndrome by proxy in lots of movies. There's been several like Netflix specials about it. So, people with Munchausen's or factitious disorder will artificially or deliberately and dramatically fabricate symptoms, or most often will self-inflict injury. So I've actually had a number of patients in the clinical setting who were consciously inflicted injuries on themselves, and they could be pretty severe. I had a patient once who would inject herself with urine. She would inject these urine feces intravenously. So, and she was a nurse, so she had access to those types of things. We have had patients who would rub feces in wounds and self-inflict rather severe infections to the point where they needed to have central lines to receive regular antibiotics. So the goal of Munchausen's or fictitious disorder is to assume the sick role. So there's also fictitious disorder by proxy, and that's Munchausen syndrome by proxy. This is when a person will inflict injuries on a dependent. Usually it's a mother to a child, and they will inflict injury to the child in order to gain sympathy, so, or gain empathy, or maybe as in the case of that one Netflix special where they did a whole series on a young girl who was horribly, brutally kept debilitated by her mother so that they could gain attention, and they got a lot of trips out of it too. So malingering is one of the fictitious disorders that's not really a disorder. This is not a medical diagnosis, and this is when a person consciously fabricates an illness or exaggerates symptoms for secondary gain. And the secondary gains can be committing insurance fraud. Maybe they want access to pain medication, or they want to avoid prison or military service. But this is all about liar, liar, pants on fire. This is just the person who wants to have or gain something, so they will make up symptoms. I actually had a patient once who took a television set and slammed it on her foot so that she could get pain medication in the emergency department. So malingering and fictitious disorder, these are conscious and they have secondary gains. Fictitious disorder is to gain attention, whereas malingering is to gain something else, such as prescription meds, avoidance of service, or maybe disability or insurance. So these are tough, very tough cases. Still, even with malingering, you've got to rule out any medical issues or treat, problems before you can say, we believe you're not being truthful. So you can, as a provider, experience a lot of countertransference as a result of persons who are not being truthful about their illnesses. So you want to avoid confrontation. This is important. Monitor for safety of patients, safety of the staff. If you suspect, like Munchausen's by proxy, which is fictitious disorder by proxy, you need to make sure that you get those folks involved who can provide safety. Often it's for children, so you would involve Child Protective Services. You want to prevent any dangerous, unnecessary treatments, and help persons to develop better coping strategies, of course. So, in summary, persons with somatic symptom disorders, conversion disorder, and or illness anxiety disorders, they are not aware of the underlying reason for their discomfort or concern. So it is important for you as a nurse to acknowledge that their concerns, their discomforts are real, and to help them to gain insight into maybe some of the underlying psychological reasons that might be the underlying basis or foundation of their symptoms. Persons with fictitious disorder or malingering, they are aware of their motivations for their conditions. Persons with fictitious disorder, their motivation is to assume a sick role, whereas malingering, there's a secondary gain that you have to identify before you can diagnose malingering. Treatment for somatoform disorders or somatization disorders is primarily focused on therapy.